Hi everyone. In this video, I'm going to talk about fetal surveillance. That includes non-stress test and the biophysical profile. But in this video specifically, I'm going to talk about the non-stress test. Just before that, there's a little paragraph regarding the fetal movements, which is also called as quickening. When can one feel the fetal movements? In primigravidas, you can feel them 18 to 20 weeks of gestational age, but it can occur earlier in multigravidas. It can also occur 1 to 2 weeks later if the placenta is implanted on the anterior wall of uterus. Alright, we recommend the high risk patients to count their fetal movements. And if there's a patient who comes to you with decreased fetal movements, we suggest them that do count those movements whenever the fetus is normally active. And we also suggest them to lay on their left side in a quiet setting because that would help them feel even the subtle movements of the baby. And here's the point to learn that how many movements do you expect? So you should experience 6 or more than 6 perceived movements in 2-hour period. But what if you don't? So if there are 10 movements that take place in more than 2 hours, you have to further assess. You have to get to the labor or delivery triage for assessment. And there are a few causes that might be the reason for decreased fetal movements. DASH is the mnemonic. Death of the the fetus. Amniotic fluid is decreased. Sleep cycle of the fetus. Yes, fetus sleep too. And hunger and thirst. So these are the differentials in which you can find decreased fetal movements. That is why we suggest the patients to count those movements whenever they feel that the baby is normally active. Okay? All right, moving forward to non-stress test. What is a non-stress test? A non-stress test is the one in which we trace the fetal heart rate. And how do we do that? We do have probes and we externally monitor the fetus. Let me show you quickly. Right here. In this diagram, we could see the external fetal monitor. There's a transducer which senses the uterine contractions, and then there's a transducer which senses the fetal heart rate. So this helps us trace the fetal heart rate in accordance to the contractions. Okay. With that, we also do have a few tracings in which we can also see fetal movements too. So that also helps explain the changes in the heart rate tracing. Okay, so we assess the fetal heart rate and its relationship to the fetal movement. How do we do that? And first of all, when do we do that? When is it indicated? If we see any suggestions of uteroplacental insufficiency or maybe the fetal well-being is being compromised, then we go for a non-stress test. And that is totally non-invasive. As I just showed you, it's just an external fetal monitoring. And we just look onto the tracing, that there's a fetal heart rate tracing and which is more than equal to 20 minutes. Okay. Then we classify that external fetal monitoring tracings into these categories, which we can see. One category is normal and the other one is abnormal, of course. But there is an in-between of it, which is called as atypical tracing. Okay. First, we'll compare the normal and the abnormal, and then anything which is left in between, we call it as atypical. But the normal tracing would be interpreted clinically as that there is no evidence of fetal compromise. So normal is the fetus is not under any compromise, and abnormal would mean that there is a possible fetal compromise. Okay, but the suggestions on the tracings would be indicative towards atypical tracing, or we could also call as a physiological response. Now, what do we actually look into the tracings and classify them? So we look on the heart rate, on its baseline, on its variability, on the decelerations, and on the accelerations. These four things are to be monitored in the fetal heart rate tracings, and these four things help us classify it from normal to abnormal and the in-between category, which is atypical. Okay, so how do we describe the non-stress test? We look at the baseline rate. We look at if there is any variability, if it is absent, minimal, moderate, marked, if there are any accelerations present or not, and if there are any decelerations, and if they are early, late, or variable. That's how we describe the non-stress test. Now, talking about the baseline. it could be anywhere in between 110 to 160 beats per minute. That's the fetal heart rate. And baseline could be anywhere in between them. I'll show you. Yes, I have prepared this little note for you guys and to explain you guys properly. Let me do this. Okay, so in this little plotting, we can see that the one in red is the uterine contraction and the one in blue is the fetal heart rate. And this small block is for 1 second. I mean 10 seconds. Sorry about that. It's for 10 seconds. And 1, 2, 3, 4, 5, 6. This whole block would be for 1 minute. Okay. So the uterine contractions would be right here, and the fetal heart rate and all the changes in the fetal heart rate would be plotted in blue. Now, we can pretty much see the baseline of this blue plotted heart rate. It lies somewhere around here, right? And that would be 135. In between 130 and 40, that would be 135. That is the baseline. So if the baseline is lying somewhere between 110 to 160, it is a normal tracing. So this is a normal tracing. We can see the baseline is between 110 to 160. What's the abnormal? If it is less than 100, then that is abnormal. So right here, we can find 100 right here. So if the heart rate is somewhere here, then that would be bradycardia. And if it is more than 160, somewhere right here, then that would be tachycardia. Right? So that would be an abnormal tracing. Moving forward, the atypical tracing would be somewhere less than 110, would in between 100 and 110. So in between 100 and 110, let me change the color. If the tracing is somewhere between here, then we'll consider it as abnormal. Or if it is more than 160 beats per minute, right here, if it is even more than it, but if it is for 30 to 80 minutes only, and after that it gets back to the normal, which was this, then it is also called as atypical tracing. Okay, so normal is 110 to 160 and abnormal is less than 100 and more than 160. But if it is something in between them, we'll consider it as atypical. That's how we look into the baseline. That's how we measure the baseline of the fetal heart rate. Okay, moving forward to variability. Here's how we could see the variability. What is variability? So basically, the fetal heart rate, if it variates from the baseline, then that is variability. It could be, and having variability in a fetal heart rate is a normal tracing. Okay? Normal tracing would include moderate fetal heart rate variability. It could either be absent or minimal too, but it should be only less than 40 minutes. But if it stays for longer, then it's not normal anymore. So first of all, the normal category is moderate, which is 6 to 25. But we can also consider less than 5 beats per minute variability normal, but that should be less than 40 minutes. Got it? Okay, let's look into this one. Now, in this tracing, I don't see any variability. It's straight up based on the baseline of 100. So there is no variability. It's a 0. Moving forward, in this one, we could see it's variable in between. So that would be, it's 110, it would be 115, 120. I would say it's less than 5 beats per minute, because it's in between them. It's less than 5 beats per minute. So less than 5 beats per minute is absent or minimal, right? So there is an absent or minimal variability in this tracing. It could be considered normal, but it should be staying for less than 40 minutes. Then we'll consider this normal. Okay? And then talking about the 6 to 25 beats per minute, here the variability is from here till here, and this is 125 and this is almost 40, right? So 125 to 40 would be what, 15? Yes, so this is 15 beats per minute, and 15 beats per minute is in between 6 to 25. So this is a normal tracing. Moving forward, this tracing, let me change color quickly. Red. Okay. So this tracing would be from here till here almost. So this is 160 and this is 145, right? Because it's touching 145. Yeah. So 145 to 160 would be, yeah, is it 160? I mean, why would I say 160? It's 175. Between 170 and 80, 175. So 55, 65, 75. So this is 30 beats per minute. So this is more than 6 to 25 beats per minute, right? So this is probably an abnormal one. So now we know how to find the normal one, which is 6 to 25, or which we could say it could be less than 5, but it should be less than 5 for less than 40 minutes. Okay. What's the abnormal one? If it is less than 5 for more than 80 minutes. If it was less than 40 minutes, then it was normal. If it is less than 5 but for more than 80 minutes. Or more than 25 for more than even 10 minutes. So more than 25, which is, we can see right here, right? It is more than 25. It is 30. And if it stays for more than 10 minutes, then we'll call as abnormal. So just remembering the normal tracing would help us know if it is normal or abnormal. So 6 to 25 is moderate variability, which is normal tracing. So this one was normal. And this one is clearly 30. If it stays for more than 10 minutes, then it is abnormal. That's how we measure variability. Moving forward. Over here we have decelerations first, but I'll let you know about accelerations first. Acceleration in the fetal heart rate, a spontaneous acceleration, is normal. It is the criteria of a normal tracing. But if we find any absent accelerations, if we don't find any accelerations, then that tracing would be abnormal. But what if we don't find any accelerations? How would we know if it is not? I know, like, we got it that it is abnormal, but what is the in between of them? So we'll give the baby's scalp stimulation, we'll give the fetus scalp stimulation, and if there's still absence of acceleration, then we consider it as atypical tracing. But if on stimulation we get the acceleration, then that would be normal tracing. Got it? How do we see accelerations? How do you find if this was an acceleration? So in this chart, you could clearly see that there is a baseline right here, 135. And we can clearly see variability too, which is in between 6 to 25. That sounds good. Now we're looking for accelerations. So the heart rate right here, which accelerated till here, is a pretty obvious acceleration. This is an acceleration too, but let's measure it. So from 135, 40, 45, 50, I would say 155. That's 20 beats per minute, right? So this acceleration was for 20 beats per minute. And for how long did it stay? So I would say that this acceleration is pretty much in between here, right? So this was 10 seconds, this is 20 seconds, and a little bit over it, so more than 20 seconds. That's how we explain this acceleration. 20 beats per minute and more than 20 seconds. That's a normal acceleration. Let me show you how. In the interpretation, we look into the accelerations. It still has two more categories. Normal if it is more than 32 weeks, normal if it is less than 32 weeks. So if it is more than 32 weeks of gestational age, what is normal? We have to have at least 2 accelerations. We found 1, right? We have to have at least 2 accelerations of fetal heart rate. They should be more than 15 beats per minute. We found 20 beats per minute. And they, from the baseline, lasting more than 15 seconds or equal to 15 seconds. We found them lasting between 20 seconds. So this acceleration was normal. If we find another acceleration like that within the 20-minute strip, then we'll fulfill this criteria. We would have at least 2 accelerations of fetal heart rate equal to more than 15 beats per minute from the baseline, lasting more than 15 seconds in the 20-minute strip. So that would be normal. And that's normal in a fetus who is more than 32 weeks of gestational age. But if the fetus is less than 32 weeks of gestational age, we would still need 2 accelerations of fetal heart rate, but the fetal heart rate, the acceleration, might be only more than 10 beats per minute. So that is 140 to 150. So this was 135 and this is 145. So that would be till here, which was this one. It's only 10 beats per minute, this acceleration, right? From here to here, the 2 blocks would count as 10 beats per minute. And it should last for more than equal to 10 seconds. How long did this one last? We would say it's lasted from here till here. That's 10 seconds, that's 20 seconds. So it's more than 10 seconds and in 20-minute strip. Then this one would be normal for a baby whose gestational age was less than 32 weeks. But it wouldn't be normal for a baby who is more than 32 weeks. Got it? This would be a normal tracing. And normal tracings are also called as reactive tracings. But then we have abnormal tracings in which we cannot even find at least 2 accelerations of fetal heart rate in a 40-minute strip. This was a 20 minutes. The requirement was within 20 minutes. But even if you cannot find them in a 40 minutes of heart rate tracing, then it would be abnormal. What would we do then? So if no observed accelerations or fetal movements in the first 20 minutes, we'll not wait for the 40 minutes to be completed. We'll stimulate the fetus by fundal pressure, acoustic vibratory stimulation, and then continue monitoring for 30 minutes. So what would the stimulating do? The stimulation might cause an acceleration. Then that would be a normal tracing. That's how we interpret acceleration. Got it? All right, now we have decelerations. Decelerations, none. Normal tracing should have none of them, no decelerations. But there could be some early decelerations. There are some circumstances when the baby shows early decelerations, which might be included in normal ones. That could be because of the uterine contractions. The uterus contracts and the baby's head contracts, and because of the vagal response, the fetal heart rate decelerates. That is one of the examples. So early decelerations could be normal, but none is a good thing too. We don't need any decelerations. But still, if we find repetitive, complicated, variable decelerations, or if we find recurrent late decelerations, or if we find a single prolonged deceleration which is more than 3 but less than 10 minutes, so in between 3 to 10 minutes, imagine 4 minutes. For 4 complete minutes, fetal heart rate is decelerating, and that's for 4 minutes, then that is abnormal tracing. All right, for that we have to go to this diagram, this tracing. Now, as we said on the red, this is the peak of uterine contraction, right? If we have the contraction corresponding to the fetal heart rate deceleration, then we call it as early deceleration. We have fetal heart rates over here, right? We're not bothering the heart rate, how much is it, what's the baseline. We're just talking about the decelerations for now. So when the uterus contracted, if we find that there is a corresponding deceleration, which we can find right here, we'll call it as early deceleration. Okay? The peak of deceleration is corresponding to the peak of uterine contraction. Then that is an early deceleration. And this is the same example which I quoted earlier, that if because of the head contraction, because of the uterine contraction, the baby's head contracted and the vagal response led to the deceleration of the fetal heart rate, then this is early contraction, early deceleration, and that can be considered as a normal tracing. But in this tracing, we can see that it is late deceleration, because the fetal heart rate deceleration, the peak of it is late than the uterine contraction. Make sense? And then we have another type of deceleration, which we call as variable deceleration. This one right here, variable deceleration. So the early and the late deceleration have a slow onset. If this is the peak and that's where they started, they go on gradually, right? Similarly, in early 2, that's a gradual decline, gradual deceleration. But the variable are supposed to have, see, right here is the peak and here's when it starts. That's an abrupt descent. Abrupt deceleration is what we call as variable deceleration. Okay, and they are called as variable too because, if we see that here's the peak of the uterine contraction, but the variable deceleration is coming right here, right here, right here. No correspondence with the uterine contraction. You can highlight it too, right? So here's the deceleration, here's the deceleration, here's no correspondence to the uterine contraction going on here. So that's how we term them as variable decelerations. We do have them in the obstetrics section. Let me find it for you so that we can cover that over here too. Yes, fetal monitoring in labor. Here's the comparison of decelerations. Early decelerations, variable decelerations, and late decelerations. So in early decelerations, you can see this was the onset of deceleration, this was the peak, nadir of deceleration, and over here we can see contraction, this was the onset and this was the peak. So in this case, the deceleration and the contraction correspond with each other, right? They mirror each other. Then that would be called as early deceleration. It says uniform shape with onset early in contraction, returns to baseline by the end of contraction. It mirrors contraction. It is gradual deceleration and it returns to baseline. It is benign, we can consider it normal. It could be due to vagal response to head compression by the uterine contraction. So that is early. Looking for the late ones first, it is uniform shape too. And recovery, uniform shape with onset, nadir, and recovery occurring after the peak of contraction. Here was the peak, and here's the nadir of deceleration. If we highlight it, this was the deceleration, but the uterine contraction was right here. So they don't correspond. So that's why we call them late deceleration. But still, they are slow to return back to the baseline, like them return to baseline gradually, and deceleration is gradual. That is why they are late decelerations. They may also cause decreased variability and change in the baseline FHR, fetal heart rate. This is termed as abnormal tracing. It could be due to fetal hypoxia, acidemia, maternal hypotension, or uterine hypertonus. Because of the uterine hypertony, maternal hypotension, acidemia, or fetal hypoxia, fetal acidemia, or fetal hypoxia. So the fetus well being is compromised. We see late decelerations. It is usually a sign of uteroplacental insufficiency, an ominous sign. Talking about the variable decelerations, as I said, they're not gradual in onset, they're just abrupt, right? And they do not really correspond with the uterine contraction. So if this is the uterine contraction, they don't really correspond with it, right? So they are variable in shape, onset, and duration. Most common type of periodicity seen during labor, often with abrupt drop in fetal heart rate more than 15 beats per minute below the baseline. Usually no effect on baseline FHR or variability. The causes of variable acceleration would be due to cord compression, or in second stage forceful pushing with contractions. So cord compression could be one of the reason, and there could be another reason, which is forceful pushing with contractions. Then the baby might show, in the second stage, the baby might show variable decelerations. And then there are some complicated variable decelerations too. In variable, we see that the fetal heart rate drop is for more than 15 beats per minute, right? But in the complicated one, it's less than 60 beats per minute for more than 60 seconds. So it's pretty long and pretty deep, and it may be associated with fetal acidemia. So here is the comparison of all the decelerations. I hope this video helped. Here's a quick UWorld question regarding the non-stress test too. A 31-year-old woman, gravida 3, para 2, at 40 weeks gestation is in active labor. The patient has had a normal prenatal course. Her first pregnancy was an uncomplicated term vaginal delivery. Her second pregnancy ended with an emergent C-section for a non-reassuring fetal heart rate pattern. She has epidural anesthesia and is feeling mild pelvic pressure. Spontaneous rupture of the membranes occurred 15 minutes ago with blood-tinged amniotic fluid. Blood pressure is 124/76, pulse is 78, and respirations are 18. On pelvic examination, cervix is 6 cm dilated and 80% effaced, and the fetal presenting part is at 1+1 station. The fetal heart rate tracing is shown in the exhibit. Which of the following is the most likely cause of this fetal heart rate pattern? Here is the fetal heart rate tracing. As we discussed, the top one is the fetal heart rate. Right here. Oops. Right here. And here is the uterine contraction. Right? So we have to see what's going on. Let me highlight the uterine contractions for you first. So here's the uterine contraction, and here's the other one. Here's the third one. Do you see with every uterine contraction there is a deacceleration, right? And it really corresponds to the contraction. Then this might be what we call as early deaccelerations. And what did we read about early deaccelerations? We read that early decelerations could be normal. They are normal. This tracing is normal. We can also see some variability, and let's see what's the baseline is. So if we say that this is the baseline, it would be somewhere around 140, right? This is 150 and that was 130, so somewhere around 140, which is in between 110 and 160. We can see the variability to some ups and some downs, and I don't see any acceleration yet. Oh, there was one, but we don't have the complete strip too, right? So in terms of decelerations, which is the prominent thing in the strip, I think that these are the early decelerations, which is normal. So what are the options? Fetal head compression, placental abruption, umbilical cord compression, uterine rupture, uteroplacental insufficiency. So out of all these five, fetal head compression is the one in which we read that because of the uterine contraction, the fetal head is being compressed, and because of the vagal response, there is a early deacceleration. Okay? So this fetal heart rate tracing demonstrates moderate variability and early decelerations. Early decelerations have a slow onset and can occur symmetrically with contractions. This results in the characteristic uniform shallow deceleration with the nadir at the peak of the contraction and return to baseline at the end of contraction. Early decelerations are caused by fetal head compression. These occur when the fetal head descends closer to the cervix, which contracts and causes narrowing of the fetal anterior fontanelle. Narrowed anterior fontanelle causes a transient alteration in the cerebral blood flow and stimulates a vagal response, which slows the heart rate. Early decelerations are benign, physiological finding, and do not indicate any fetal hypoxia. Therefore, these decelerations do not require intervention. Choices B and E, placental abruption and uteroplacental insufficiency, typically cause late decelerations because these might cause the baby to go into fetal hypoxia. Like early decelerations, late decelerations have a slow onset, but unlike early decelerations, they are delayed compared to the contractions. Late decelerations begin after the onset of contraction, nadir after the peak of contraction, and return to baseline after the contraction. Let me show you the corresponding contractions too. Decelerations too. So first we read the early deceleration right here. So that was this one, in which it corresponds to the contraction. Symmetrical. Nadir of deceleration corresponds to the peak of contraction. Nadir, peak. Gradual, more than 30 seconds from onset to nadir. Etiology, maybe fetal head compression, maybe normal fetal tracing. Then we read late decelerations in placental abruption and uteroplacental insufficiency. So here's the late one. If we trace the peak of contraction and if we trace the nadir of deacceleration, then that doesn't correspond. So delayed compared to the contraction. Nadir of deacceleration occurs after the peak of contraction, but it is still gradual, just like early deacceleration. Etiology would be uteroplacental insufficiency. It could be because of anything, because of placental abruption. Then we have variable decelerations. That's because of umbilical cord compression, which have an abrupt onset and a variable duration and depth with each deceleration. So here we have the deacceleration. So the onset was pretty abrupt. You can see this dotted line and this dotted line. The difference between is pretty abrupt. But we can see this dotted line and this dotted line here, from the onset to the peak, it is pretty gradual. So this is pretty abrupt. And it could be the depth or the duration could be anything. And etiology would be cord compression. It could be because of oligohydramnios. It could be because of cord prolapse. So the option was umbilical cord compression results in variable decelerations, which have an abrupt, we talked about it. Uterine rupture, that's a total different story. It may cause bradycardia, variable decelerations, and late decelerations due to the concomitant fetal hypoxia or umbilical cord compression. So it includes hypoxia. So hypoxia would lead towards late decelerations, and the umbilical cord compression, because of the compression, the sudden compression, there would be abrupt variable deceleration. So it would be a combination of both, and we'll see bradycardia. So the tracing wouldn't be anywhere. It hasn't labeled. Yeah, it's not labeled over here, but the tracing right here. So this was the normal, right? 110 to 160. So the tracing in a uterine rupture would be somewhere right here. Bradycardia. Okay. And there would be a ruptured uterine scar too, through the ruptured uterine scar. So the objective would be early decelerations are uniform, shallow decelerations with gradual onset that occur symmetrically with contractions. They nadir at the peak of contraction and return to the baseline at the end of the contraction. Early decelerations are a benign finding caused by fetal head compression, which leads to physiological vagal response. I hope this helps.